Doctor, thank you so much. And again, did not mean to interrupt you, and I'm grateful that you're here. Thank you so much. What I'd like to be able to do is open it up for questions and see if the senator, and thank you so much. I know you've had a really busy day today. Do you think, Senator Bell, and if you had any questions or comments, sir?
Senator Mitchell and I wrote a letter in November requesting data information, and we're interested in seeing when that data is going to be given to us, and some of it has. We would like to know, on behalf of Senator Mitchell and I, when that will be completed.
I believe that's mine. We have submitted data as recently as yesterday. We are working through the list. It's a very complex and labor-intensive process, and so we're working through the list to try to get you your data, and we're prioritizing your request to get this data to you as soon as possible.
Okay, thank you. And when do you think it'll be completed, you think?
That I'm not sure. I'll have to go back and ask, but I know that they're working diligently on it.
So it's not going to be impeded by anything in any way?
No, they have given this a priority.
Okay. Thank you.
Anything else? Thank you so much. I have a few questions. I heard, again, thank you, 5 of you for being here, and know how busy all of you are. I heard one individual on the panel, Mr. Mecca, talk about, and I'm going to paraphrase here, sir, concerns over the volume, my words, of psychotropic drugs being used in the foster care system. So I heard one individual out of the panel. So and then we heard, just being candid, about how folks are working together, and executive team has been established, a community team's been established.
Yeah.
But I think that the frustration is that, and again, I'm looking at Mr. Lightbourne. Mr. Lightbourne took the position in 2011. So it's a royal you. What I'm concerned about is we can't go on with the status quo. And we all knew that this hearing today is based on, and it may be my editorial, but I believe the data is on our side, is the misuse of psychotropic medication within the state foster care system. And I heard one individual address the issue. So I'd like to be able to hear, are there concerns about the volume of psych meds in the foster care system here in California?
There's very deep concern about the volume. The question becomes not to say all usage is inherently wrong.
Correct.
It's finding what is needed for which individual child or youth in care. And I think implicit in the goals that we shared in the slide deck, the PowerPoint, were the reduction of usage, the reduction of polypharmacy, and the increased use of psychosocial. All of that says, yes, we want to bring that number down. We also know, as we've discussed in prior panels, that the utilization rate is extraordinarily high in congregate care settings. And hence, a major part of the reason for the continuum of care reform agenda and the strategy for reducing the use of congregate care, restricting it purely to specific treatment purposes, and then having psychosocial services following children into family-based care, either relatives or foster family homes, is specifically to reduce the overuse and particularly use for behavioral control reasons. So I just want to be very clear that that's our position.
Absolutely. And as we've seen, with all due respect, I think back in 2006, there were a lot of discussion about some of these same issues that were brought up on med control. And we've actually seen an increase since '06. So I think that's where the concern lies. So let's just talk about that a bit. The doctors and incentives. And there's been a lot of discussion about physicians essentially receiving incentives when it comes to just distribution of medication to foster youth. Do you want to comment on that a bit?
It's very troubling. I mean, as the point was made on a prior panel, Vermont has actually legislated against it. I think the whole notion of enticing the use of what is potentially a dangerous drug, and particularly used in interactions, is abhorrent. And I particularly like the comment of the person who said, went to one dinner, realized it was bait and switch, realized exactly what the deal was, and that, not going back. To the extent we can, as a state, restrict that, I think that's all to the good. As we develop the evaluation instruments that are going to be part of reviewing the work of the short-term residential treatment centers under CCR, as well as the FFA treatment programs, one of the things we will be looking for is the incidence of use, rates, length of use. Do they step down promptly into non-congregate care settings? Those are exactly the sort of outcomes that this whole measure is to track against. Not having been part of the 2006 dialogue here, I was then sort of in county incarnation. What I think we didn't do in 2006 was we didn't restructure the placement system. And the treatment, whether it is psychosocial or it is based on chemical or medication, is nested in the ecology of the placement system. And we have continued to have a placement system that doesn't match our stated intentions. What we've now committed to as an administration and what we have as proposals coming to the legislature is a restructure of the placement system and a restructure of where services are delivered so that we never move children to a place because that's where services are. We move services to where the children are.
And I think just carrying on that, and thank you, Director, for that, is that, and I think you said it yourself, it's going to take some significant time to transition.
Yep.
And from my research, what I've seen is that particularly in group homes, you have individuals that either contract with the group home manager or actually has medical staff on board with their own staff that are prescribing these medications. And the state simply is not tracking that. And so I guess where my piece is California has to be focused. If we're looking at a wholesale change, and as we know, it's going to take time, but these foster youth don't have the time, and the longer we wait, the worse the outcome is for foster youth. So let's get into that a bit about your thoughts on that.
The data sharing systems that we're now developing between DHCS, CDSS, and with the counties is basically intended to track the individual cases of children and youth who are being prescribed. That then equips the county both in its role as parent, in its role as case manager, but also in its role as the placement entity to know which providers are doing what. It also equips us as the licensing agency and as the program oversight agency to know which group homes are having high incidence of use. And in the short term, we will certainly be very close, very attentive to those situations. But as Mr. Rodriguez and Ms. Hoffman sort of noted in the first panel, ultimately what's going to be, in response to Ms. Hancock's question, or Mr. Monning's question as to what makes the difference, they said being in an environment which the supportive relationships and the love. So even while we do it from an enforcement point of view, which we will be doing, we have to move to an environment where the ecology makes sense, as opposed to contradicts what we're trying to do.
And I hear that, and I think that the challenge that I've seen, and we've had some individual meetings within the North Bay area, and my concern is that when you talk with individual directors within the child welfare system and individuals with the mental health system, it's like this. And there are significant gaps that exist about who is ultimately responsible and why there are problems. And I think we've all heard this. And I think that we still have a significant road to travel to be able to get there. And so that is a concern that, particularly in the short term, that gap is still, my opinion, and anecdotal. When we pull individuals together from the North Bay area, it is at times contradictory of the individuals who say one thing, then you have child welfare saying one, mental health saying another.
I think it's important to note that there has been historic disconnects. Part of the whole core practice model that lies behind KDA is literally how, it's not enough to get mad at it. You got to find a way to mesh it. As Ms. Baylor mentioned, we and they have been emphasizing to the counties that EPSDT is an entitlement. It is to be provided. There may be capacity issues. There may be issues of building referral connections and systems. That's all stuff that we're sort of engaged in actively now. This isn't a aspirational, we will get to it. This is work that's going on the ground now. And those counties that are effectively engaging through the KDA process, through the and claiming to the Medicaid side of that process, are proving they can do it. It's not going to be complete tomorrow, however.
Which is why, again, I think that we need to be able to stay on this, and why we're going to be having another meeting. And Mr. Lightbourne, just one other item, and I know other panelists want to be able to comment on this, is that I think the other issue that I have concern about is that there's been some discussion about services that are available for foster youth. And I am not an expert, but what I've seen as a member of the Board of Supervisors is that there are challenges of providing foster youth early on the services when there's transition from the home that they're being taken out of to either the group home they're being placed in or the individualized home. And then what we do is rely on the pill to be able to look at behavioral control as they are trying to get settled into the new placement that they're in. And then as we see, it's inconsistent level of mental health services throughout, particularly in the group home system, which I know you're very focused on the continuum of care. And I say all this is because this is going to take additional funding. We're spending nearly $250 million on psychotropic drugs now through Medicaid, and I think 72% of that is on foster youth. Can we look at additional investments, because that's what it's going to take, right, is additional investment to be able to provide additional wraparound service?
Yes, and what it's going to take is as part of the system that is already being put in place, sort of the strengthened, upfront, trauma-informed assessment of every child coming into care, particularly using the child and family team approach, and not having children have to fail up into higher levels of care, but have children begin with the care they need, and particularly with the trauma remediation services that they need. And that will take resources.
And I think that's going to be the challenge, whether it is realignment dollars that have been discussed and or additional dollars as we see this economy turn around. And again, just being frank and not at all, it's royal, Mr. Lightbourne, right, is that that's where we have faced challenges as a state. When we look at these type of reforms, it takes dollars, and it either dies at appropriations or it's not signed, the legislation that is. And I think that's where we need to be able to focus.
It has to become a mutual priority.
Absolutely. And I don't know if anyone else wants to be able to chime in. Please, Mr. Maka.
From the standpoint of the County Human Services administrators, there's more than three things, but there are three key things that we believe we need to improve oversight and care for kids, particularly kids who've experienced significant trauma. The data that Mr. Lightbourne talked about, so that we know a lot more about what children are taking and how it's affecting them. We're co-sponsoring with the National Center for Youth Law SB 238 Mitchell. Mr. Bell is a co-author of that measure.
That's the data bill.
The data bill. So we're armed with information, not just for us, but for court-appointed special advocates and attorneys and caregivers and judges, so we all know more. The second thing we need are more family homes and relative homes. So much of what we've discussed presumes that we have families to take youth in lieu of children being in higher levels of care, more restrictive levels of care. And we have a significant shortage in the state of California.
Yeah.
Partly that's due to the success of AB 12, which extended foster care to 21. Because more kids are staying in the system with their caregivers, fewer caregivers are then turning over and available. But compared to the number that you cited for how much we spend on psychotropic medications, the state spends about $2 million for foster family home recruitment, retention, and support. The continuum of care reform proposal that the governor put out in the January budget identifies that gap, identifies a need for more resources. We respectfully, to all members here, believe that that investment needs to be significantly higher than even the governor proposes in January. But in order for youth, Ms. Rodriguez was right, in order for youth and caregivers to be able to normalize experiences so kids can be in soccer and debate and cheerleading and music, and in order to recruit high quality families, in order to give them the mentoring and the respite and the training they need, we need more resources. Because all of those reforms in the Venn diagram that Mr. Lightbourne put out, KDA, continuum of care reform, QIP, all of those depend on an adequate supply of high quality family homes. And we would like to work with you on our legislation and our budget proposal, which we believe could help accelerate our efforts forward, knowing that we have a long way to go.
Absolutely, no, thank you so much, and I look forward to working with you. Thank you, please.
Yes, if I may, Chairman McGuire, I'd like to respond to your question about incentives that physicians may have been taken to prescribe psychotropic agents to children. If for a moment I can wear my hat of the Ethics Committee of the California Medical Association and my hat as a member of the Ethics Committee of the American Psychiatric Association, I would strongly state that any physician who takes monetary incentives to provide a certain type of medication is unethical. And I would expand that to say that any provider who takes monetary incentives to provide any service which does not help an individual child, particularly in the foster care system, is equally unethical.
Do you think that, and I'm not going to put you on the spot and ask you about Vermont, but do you believe that there needs to be reform related to the issue of incentives? Because I think whether it is specific financial incentives or extracurricular incentives, those incentives are being offered and frankly taken. So, and we know that. So do you believe that there should be some reform, particularly focused on psych meds for those docs that are prescribing within the foster care system?
I think if there are currently any who are taking incentives, monetary or otherwise, to prescribe psychotropic agents to foster care children, there should certainly be reforms implemented. What those reforms might be, remains to be seen.
No, absolutely. And I think that what the data has shown is those individual physicians that are involved within the foster care system in the state, we do see a higher number of incentives, extracurricular, financial, or otherwise, right, that are being distributed. So that is, and I hear you, and I appreciate that.
Yeah, and you may or may not be aware of this, but Congress has taken some steps along this regard, especially in the area of continuing medical education for physicians. I happen to chair the Continuing Medical Education Committee for LA County Department of Mental Health, and as such, we are held to a standard whereby we are essentially precluded now through the AMA and the CMA in having speakers provide education to our psychiatrists who have these conflicts of interest. And then, of course, Los Angeles County, and I believe many other counties, have policies in place to discourage that kind of behavior.
No, thank you so much. I appreciate you going into that. Thank you. Please.
I apologize if you didn't hear my concern earlier regarding the overprescribing, and we share that concern with you and are willing to work with you to make the fixes necessary. I agree with what the panelists have said about some of the things that we are working on and things that we can work on to make improvements, but I was very moved by the first panel and talking about their experiences. And I've been in this field for 30 years, and my first job was working in a group home. And I went in totally unprepared, did not have the training. We didn't even, this is many, many years ago, but we didn't even talk about trauma back then. And so I do think there needs to be education of the professionals regarding trauma-focused treatment. We would like to see there never be any foster care or any child prescribed psychotropic medications. In fact, if I can be so bold, I would love to put Will Lightbourne out of business and have no child removed from their home. But I think in this conversation, we also need to look at why are the children removed from their homes? And are there interventions such as more substance use disorder services that we could provide, which, especially through the waiver that we're working on now, that would help prevent? There's also the Child Welfare Council also has a PASS program, which is giving kids who are up for reunification priority access to services. And so we'd like to see a lot of these efforts be successful so that children are able to maintain those relationships with their parents and to be able to stay home.
Thank you. And I really do appreciate that clarification. And just want to say thank you for your passion as well, because I could tell it's very personal. So thank you so much. Anyone else? Please, Doctor.
Yes, since I have all of you captive,
Yeah.
I'd like to make in a plug for supporting families before they become clients of the child welfare system.
Yeah.
And I think if there are investments in that arena, we would go a long way toward not only decreasing the number of children being removed from their home, but the use of psychotropic agents and other kinds of interventions that they wouldn't need.
No, thank you so much, Doctor. Senator Bell, I want to see if there's any follow-up, please.
Just to tell you, one thing I'm doing that's relevant to that and some of the issues I know that you care about. I'm preparing an audit request of the program for behavioral health in the schools. That was taken away from the mental health system a few years ago, and it was done during the budget process. It was done in the Budget Act, and there was no policy hearings or discussion about what that meant to transfer this program from the mental health programs. I think you were a mental health director at the time, right? Yeah. Okay, and so you know what I'm talking about, and you were too. So transferring it from the mental health programs to the schools, okay? But there is now no measurement. We don't know what's going on with these kids, how they're coordinated with the mental health and social service systems, how many of these kids are foster youth. They don't track any of that. So I think there's an element there that needs to be worked on. I request an audit. There's going to be an audit done by the state auditor if the audit committee, which I'm a member of, approves it. And then it will go subsequent to develop with my colleagues in Human Services here some legislation to put the coordination back where it should be. We should have had a policy discussion before we did such a thing that affected, I think it's about 80,000 or 100,000 children that have seriously emotional disturbances. And we should have done something on a policy level before. We should never do these kinds of things in the Budget Act. We should always do them through the policy committees. So I think one of the things about kids is we ought to say nothing about kids unless it goes through a policy committee. I think we ought to agree with that. We should have careful clear understanding of what we're doing before we go ahead and do these things. So anyway, that's going to be requested. I hope people support that.
Thank you very much for that. We really look forward to that.
I want to say thank you to our panelists, and let's give them a round of applause for their hard work, please. So, ladies and gentlemen, we're now moving on to our next panel, and that's on local systems of oversight and care. But before we do, I want to remind you that we need to continue to advance this issue, which is why you're going to be seeing a second oversight hearing later this fall focus on this this issue at hand today, along with the Continuum of Care report. And we encourage you to please stay connected on this important issue, as we are not going to allow this to be deferred. Our local systems and oversight and care panel is going to provide a deeper understanding in the local systems of care that may be in place from the perspective of county child welfare, the courts, and foster care providers. We're going to be asking how counties and providers can work together more effectively to ensure that kids on psychotropic medications receive the care they need, and that all foster children receive appropriate services that might prevent the need for those medications. We have a tremendous panel, and we're grateful that everyone is here. We have William Grimm, Senior Attorney from the National Center for Youth Law, Lynn Thal, from the Alliance for Child and Family Services, Brenda Parrish, Public Health Nurse from the County of Alameda. We're grateful. We have Judge Michael Nash, Superior Court from Los Angeles County, and I just want to take a moment to say thank you to Judge Nash for his amazing advocacy on behalf of juveniles throughout this state and for youth. He's truly a leader, as well as Laureate Medina, Director of the Santa Clara County Department of Family and Children's Services, who's going to be speaking with us as well, and home to Senator Bell. And we do want to say thank you to Majority Leader Monning, who is back from his other meetings, and we're grateful for all of your time, sir. Thank you so much. So let's kick this off with William Grimm, Senior Attorney with the National Center for Youth Law, who will be providing 4 minutes. Thank you so much.